Good afternoon, all.
Just a minute. Is Dr. Shraddha Raj present now? He was absent in the beginning. Not present even now? Okay. Please go ahead.
Good afternoon. So my paper is artificial intelligence to predict the sensitivity of the diagnostic parameters for the early glaucoma. So many times early glaucoma pose a unique set of challenge. So many times the IOP is borderline, disc changes are not clear cut. Even the patient is not able to do the perimetry properly, or even the OCT is showing some equivocal changes. So many times the dilemma comes how we go ahead. And to add to this confusion, like initially the EMGT study mentioned that sometimes in early glaucoma there's visual field defects comes even before the structural changes appears. However, the many other studies have shown and otherwise, like structural changes usually comes before the functional changes, but this relationship is not uniform, and the measurement variability further adds to the confusion. So the objective of our study is to evaluate the diagnostic ability of the different perimetry program 24-2, 24-2C and 10-2 along with the OCT in diagnosing the early glaucomas using with the help of the artificial intelligence, and to study the consistently altered parameters in glaucoma patients. So this is a prospective cross-sectional study and conducted in the Shingar-Tastari Eye Care Centers, and the normal and glaucoma subjects who gave their consent were included and ethics committee approval were taken. And subjects were divided in glaucoma suspects and normals. So the patient with having the disc suspects like a high cup disc ratio or cup disc asymmetry or neuroretinal rim changes or nerve fiber layer defects, or either with the high IOP like more than 21 mm of HG on 2 occasions with the GAT, or visual field defects, or person having the primary angle closure glaucoma with the more than 180 degree of iridotrabecular contact in which the laser PI has been done. So the person presenting with one of this criteria, not fulfilling all of this criteria were included. And the exclusion is if a person is not able to perform the visual field reliably, or the OCT scan has not come properly, or any confounders like systemic or neurological comorbidities that might have confounded the visual field results were excluded. And if a person has undergone the other surgeries apart from normal cataract surgery has been also excluded, and the extremes of refractive errors were also excluded. So all the persons underwent the detailed clinical examination, and the visual field assessment was done with the 24-2 CETA standard and 10-2 CETA standard and 24-2 CETA faster program. And OCT RNFL was done using the TopCon Triton OCT RNFL and GCC analysis was done. So all these scans were done on the same day. Random eye was chosen for the first for the examination, and adequate rest was given between the tests. So the visual field data like zonal mean and standard deviation from 10 degree, 20 degree and 30 degree zone was calculated, and the other machine derived parameters like VFI, pattern standard deviation and mean deviation was included, and the OCT parameters like RNFL thickness, cup disc ratio, disc area, cup volume and GCC thickness were included. So all these parameters were put in leave one out validated random forest AI classifier, and each parameter was considered as a feature and outcome as a response. So the 3 modules we have designed, like visual field only, visual field with OCT RNFL, and visual field with OCT RNFL and GCC were included. So this so the demography is like 72 eyes of the normal subject and 271 eyes of the glaucoma suspect were included with the age of 44 and 50 years respectively, and the IOP was 14.8 and 15.38 respectively. So when we see the VF derived parameters, mean deviation and the VFI showed a difference between the glaucoma, statistical difference between glaucoma suspect and normal on 24-2 and 24-2C program. Same pattern follows when we consider the 10 degree mean and 20 and 30 degree mean also. When we see the OCT parameters, only the inferior RNFL and total RNFL shows a significant difference. When we study the modules, the VF parameters only has a AUC of 0.68, but when we include the OCT parameters, the AUC increased to 0.95 and further increased with the addition of the OCT, GCC, RNFL. And same thing, confusion matrix also, but the VF, the high false positive rate was there, but it decreases the false positive rate when we include the OCT parameters. And when we study the top 10 rank parameters, the inferior RNFL thickness came as a first predictive parameters by the AI. So in conclusion, like both OCT 24-2 and 24-2C are effective in predicting the early glaucomas, but when we add the OCT parameters, the predictive capacity increases. But the limitation is small sample size and only South Indian population was included in our study.
So what method of AI did you use in this?
This is basically random forest AI model, and which is a leave one out validated model. So in this leave one out validated model, so for the AI training we use the first we use the test set, and then first the training set, and then we use the test set. So in leave one out validated model, each observation act as a test set, and all the other observation was considered for the training. And this process is repeated until all observations are included in the test set. Like that.
Because all these devices need to be well validated before we can come to any conclusion.
Yes, ma'am.
Thank you so much.